Dr. Baliga here. I have another terrific God Knowledge Doc podcast for physicians and advanced practice providers, including physician assistants and nurse practitioners. You should find this podcast very useful in your practice. This podcast is on imaging in cardio-oncology, a brief overview. I've served as the inaugural cardio-oncologist at the Ohio State University Wexner Medical Center at the Ohio State University Cardio-Oncology Center of Excellence, and I was also the inaugural co-editor of the International Cardio-Oncology Society Board Review Manual. This is a terrific manual, and anyone wanting to know more about cardio-oncology will find this as a very useful resource available at the International Cardio-Oncology Society website. My other acknowledgments is that a lot spoken today is derived from an editorial I wrote with Dr. Jim Young from Cleveland Clinic, while we both served as the consulting editors for heart failure clinics of North America. I'd like to also thank Dr. Daniel Addison, Dr. Arjun Ghosh from England, Dr. Thura Harfi, my colleague, and Dr. Daniel Lenihan from St. Louis for sharing the slides which helped me shape this talk. In this terrific chapter on cardiotoxicity in a color atlas and synopsis by McGraw-Hill, which I edit, Dr. Dan Lenihan and Dr. Singh talk about all the cardiotoxicities we can see with cancer therapies. We know about anthracyclines and trastuzumab. They cause LV systolic dysfunction. Radiation causes premature coronary artery disease, affects the valve, may affect the myocardium, causing myocarditis, pericarditis, cardiac arrhythmias. And the key drivers for radiation are a dose more than 30 gray and when the heart is in the field of exposure. Other medications like alkylating agents like cyclophosphamide can cause heart failure. Platinum agents like oxaliplatin, cisplatin, carboplatin can cause myocardial ischemia, high blood pressure, and LV hypertrophy. 5-fluorouracil can cause vasospasm, myocardial ischemia, and paclitaxel can cause cardiac arrhythmias and thrombosis. The novel therapies, including trastuzumab and the VEGF signaling pathway inhibitors, can cause hypertension, proteinuria, cardiomyopathy. And the tyrosine kinase inhibitors have a plethora of effects. Dasatinib can cause pulmonary hypertension. Nilotinib can cause peripheral arterial disease. Ponatinib can cause vascular events. Ibrutinib can cause AFib. And as these agents continue to grow, we're seeing the whole spectrum of cardiovascular complications. Thalidomide and lenalidomide can cause thromboembolism in the arteries and veins. Proteasome inhibitors, which can cause hypertension, heart failure, venous thromboemboli. Checkpoint inhibitors like nivolumab and pembrolizumab can cause myocarditis, and androgen deprivation therapy can cause dyslipidemia, hyperglycemia, increased subcutaneous fat, and coronary artery disease and vascular disease. This slide on the left panel shows a thrombus causing turbulent flow in the left proximal femoral vein and extending into the calf veins in a patient receiving VEGF signaling pathway inhibitor, pazopanib, for advanced renal cell cancer. The right panel shows a patient who developed symptomatic high-grade severe stenosis of the proximal LAD while receiving chronic androgen deprivation therapy for metastatic prostatic cancer. This is from a terrific chapter by Dr. Lenihan in the Color Atlas and Synopsis of Heart Failure, edited by me. One of the things I'd like to bring to attention is the cancer patients go through a lot of screening tests by oncologists. For example, in this patient in the left panel, he was having an MRI plain film before they actually do the MRI, and it reported vascular calcification in the thoracic aorta. This is a patient with bone mets. And the very fact that he had vascular calcification in the thoracic aorta prompted me to check his lipids and initiate lipid therapy. On the right side is actually a CTP study done on one of the patients referred to us for heart failure. And if you see at the middle of the panel, there's a report from the radiologist, extensive coronary artery calcification, atherosclerotic aorta without aneurysm. So when the patient was referred to me, this prompted me to check his lipids, and then based on these findings, we initiated statin therapy. Multimodality imaging can be used to stratify patient risk, to identify cardiovascular injury during and after therapy, and to forecast recovery. For cardiotoxicity, the imaging modalities used are echo, CMR, that is MRI, PET scanning. For ischemia workup, we use stress echo, stress MR, coronary CT, and PET. This is a terrific review by Dr. Plena et al. In JACC Imaging, which talks about cardiovascular complications of therapy, including LV dysfunction, pericardial disease, coronary artery disease, pulmonary hypertension, and aortopathy. And on the right side, the table actually lists all the agents which cause these cardiac manifestations. For example, pericardial disease is due to radiation therapy, methotrexate; coronary artery disease due to antimetabolites, antimicrotubule agents; pulmonary hypertension due to small molecule tyrosine kinase inhibitors; and vascular toxicity due to anthracyclines, tyrosine kinase inhibitors, monoclonal antibodies, proteasome inhibitors. So you see in the last column, there are the plethora of agents of imaging modalities we can use to diagnose the toxicity due to cancer therapies. When it comes to cardiac dysfunction or LV dysfunction due to chemotherapy, particularly trastuzumab, the ranges used are in the right column. You will see when there's an absolute decrease in ejection fraction greater than 16%, then we hold trastuzumab. In the left, in the second column, you see when the absolute decrease is less than 10%, we continue it regardless of baseline ejection fraction. But when the absolute decrease is between 10 to 15%, we will only continue it when the baseline ejection fraction was within normal limits. When it was 1 to 5% less than the lower limit of normal, that is LVEF of 50, we hold therapy. Similarly, when it's greater than 6%, we hold therapy. So this is kind of the behind the envelope approach, which is used in clinical trials to either to hold, continue therapy with trastuzumab. This is from the editorial we wrote with Jim Young. The important thing about ejection fraction echocardiogram is to realize with 2D echo, the coefficient of variation for LV systolic function can be as high as 15%, intra-observer variation, making that the smallest significant change in ejection fraction that can be detected is approximately 11%. Similarly, the test-retest variability of LV volumes varies between 11% for end diastolic volume and 15% for end systolic volume. Given these challenges, in our program, now all our echocardiographers, especially in our chemotherapy-induced cardiotoxicity patients, will compare the echo they're reading that day with the previous echo so they can give us a realistic trajectory of the changes in ejection fraction in our patients. Another option which is emerging is 3D echo because it's a lot more reliable. Strain imaging is also emerged as an important modality in the toolkit of our patients. Strain imaging has superior reproducibility when compared with LVEF. The strain imaging derived parameters are highly reproducible, with low inter-observer and intra-observer variability. And we have been using roughly about 15% as um, a change in 15% as an indicator whether to initiate therapy for LV dysfunction in response to chemotherapy. So this is now standard of care. So you can have peak longitudinal strain obtained through spectral tracking, and we can have circumferential and longitudinal strains, and these are now standard of care. For peak longitudinal strain, we use spectral tracking from 6 regions of interest that are independent and occur almost simultaneously in the patient. Hot off the press is this very important article published by Dr. Dinesh Tavindrinathan in JACC Cardio-Oncology, November 16th issue. The key takeaway from this very important paper is that using echocardiography and patient demographics, one can risk stratify those highest risk for cardiovascular disease. They found age above 50 years, an E to E prime ratio greater than 7.8, and a GLS less than 18 associated with worse prognosis, and they were able to risk stratify patients depending on these 3 criteria from group 1 to group 7, group 1 having no risk, and these were younger individuals with normal GLS and normal E to E prime, and those in group 7 with the worst prognosis were older individuals with an abnormal E to E prime and an abnormal GLS. It's a must-read article for those who want to manage their patients over the years. Cardiac MRI is the gold standard in the evaluation of LV function and has a high spatial resolution. The main advantage is its low intra-observer and inter-observer variability. However, cardiac MRI is also not amenable to sequential imaging in the physician's office. On the right panel, in a paper I reviewed for acc.org, this paper was in JACC in 2019. It suggested that T2 mapping during therapy identifies intracardiomyocyte edema generation as an early marker of chemotherapy-induced cardiotoxicity. Now, native T1 is measured in milliseconds, is increased when the interstitial space is expanded, for example by fibrosis or amyloid deposition or edema, whereas T2 measurements provide an estimate of tissue water content. For example, T2 is elevated during acute myocarditis and following acute myocardial infarction. This study suggested that T2 during therapy is the earliest marker of anthracycline-induced cardiomyopathy. Another study, which was recently reported in JACC Imaging, found that MRI has limitations. It appears that it is prudent for the same reader to ascertain the T1, T2, and the ECV values, the extracellular volume values, at different time points whenever possible for serial imaging, particularly in patients suspected of chemotherapy-related dysfunction. In another paper which reviewed in acc.org in 2016, the main strength of cardiac MRI, especially when using the Lake-Lewis criteria for myocarditis, is the high specificity and positive predictive value, whereas the sensitivity of MRI to detect myocarditis is variable and depends on the time and point when it's done in the trajectory of the myocarditis and the protocol of the scan. Therefore, it is important because these findings suggest that sensitivity can be improved with the choice of MRI technique. In a terrific chapter in the same color atlas and synopsis of heart failure, Dr. Emily Rudin and Carolina Zariba talk about different hyperenhancement patterns. For example, on the right side is non-ischemic LV dysfunction. Mid-wall hyperenhancement is seen in myocarditis, and and that could be either near the LV septum or in the free wall. You can have epicardial hyperenhancement in myocarditis, but in the lowest panel in C, the global endocardial hyperenhancement is seen in amyloidosis. So remember the patterns: mid-wall, epicardial, and global endocardial hyperenhancement. We talked about the different techniques which can improve the assessment with MRI, and these include late gadolinium enhancement, which I just spoke about, T1 mapping, extracellular volume fraction mapping, T2 mapping, and cine imaging. And in this terrific paper by Palinesh Nathan in JACC this year, showed that we can actually confirm immune checkpoint inhibitor myocarditis, or say it's likely, or even say it's unlikely, depending on using these different MRI parameters. So MRI has been evolving. It's more sophisticated than 4 or 5 years ago, and I think it is our go-to test as we move forward. This is a patient with chemotherapy-induced cardiomyopathy, and it's interesting that the top figure shows that the LV is severely dilated on MRI, and the lower figure, the late gadolinium enhancement, reveals the presence of mid-myocardial fibrosis within the septum, consistent with an underlying non-ischemic process. Very recently, just last month, Chetan Shenoy from Mayo Clinic and colleagues showed that MRI is terrific in suspected cardiac tumor. It has a high accuracy, excluding a cardiac tumor. It offers unique ability to differentiate between various diagnostic possibilities, particularly when differentiating thrombus versus tumor, and I have done that for many of our patients. And it correctly distinguishes benign from malignant tumors owing to its excellent soft tissue contrast and high spatial resolution. In in cardiac amyloid, especially in TTR amyloid, the screening test is now the technetium 99 pyrophosphate scintigraphy. You will see that in the left panel, the left side confirms myocardial uptake by the heart immediately, and is present even 3 hours after post-injection, indicating clearly that this patient has TTR amyloid. The right figure shows the same, shows the concentration of the TTR of the pyrophosphate technetium pyrophosphate label in this patient with TTR amyloid. This is an echocardiogram of a patient with AL amyloidosis demonstrating thickened interventricular septum and posterior wall left ventricle. This is from a terrific chapter by Dr. Moira Gertz and Dr. Timur Sher from Mayo Clinic. Dr. Gertz is chairman of medicine, he contributed a terrific chapter on amyloid heart disease in the Colors Atlas and Synopsis of Heart Failure. In the same chapter, this figure shows a non-contrast MRI, figure A, and post-gadolinium MRI in the top panel, which show amyloidosis. The left panel shows left ventricular wall thickening, and the right panel shows delayed subendocardial enhancement and highly suggestive of infiltrative cardiomyopathy. And the lower panel shows a CT scan, which shows myocardial thickening and bilateral pleural effusions. This figure shows, this is by Dr. Emily Rudin and Carolina Zariba. This MRI shows pericardial effusion, bilateral pleural effusions, LV thickening, and the right two figures show late gadolinium enhancement images with diffuse LV hyperenhancement. And finally, we're using T1 mapping, which was abnormal in this patient with amyloid with the gadolinium. The T1 mapping was 82% and normal is less than 29%. So MRI is great to diagnose amyloidosis. This talk is from Color Atlas and Synopsis of Heart Failure.